Good morning or good afternoon, depending on where you're joining us from, and welcome to the How Safe is Your Care webinar. My name is Jennifer Zelmer. I'm the CEO of Healthcare Excellence Canada, and it's my very great pleasure to be your host for today's conversation. If we can move on to the next slide, please. So just a couple of things before we get started. Cet webinaire aujourd'hui est disponible en français. Si vous voulez écouter en français, veuillez sélectionner French dans le menu d'interprétation. A reminder that this webinar will also be recorded today to allow either you or others to be able to view it afterwards. And as we move into the webinar, I will move to the next slide and acknowledge that I'm joining today from traditional unceded Algonquin territory, where I'm so fortunate to be able to live, work, and play. And as I've learned more about the traditions of the place where I'm joining from today, which is near the intersection of the Ottawa and the Rideau Rivers, I've learned that this has always been a place of learning, of exchange, of meeting. And so hopefully in this virtual way today, from coast to coast to coast, we can build on and continue some of those traditions from this place in this new virtual space. And I invite you to take a moment to introduce yourself in the chat and to reflect on the land where you're joining from today, lands that have been walked by Indigenous peoples since the beginning. And it's our very great pleasure from coast to coast to coast today as Healthcare Excellence Canada to host today's webinar. As many of you would know, we're an organization that is focused on shaping a future where everyone in Canada has safe and high quality healthcare. So today's topic absolutely is central to that work, whether it's the work of identifying the points of light across the country, people who are working on wicked problems and the innovations that come and provide us with opportunities and hope, or the rapid adoption of proven innovations as we move forward. Building the capabilities to do that work well right across the country, and recognizing that frontline teams can do amazing work, but need to have the structures and policies in place to make that work easier to do. And so catalyzing policy change as well. Underlying all of that, we need to thread through the importance of safety because everyone in Canada wants and deserves safe care. And that's really what today's topic is about. So if we move to the next slide, I am delighted to introduce you to our fantastic panel today. And you see their formal organizational affiliations on the screen. If I did their formal introductions, we could use up the whole webinar by introducing the various hats of folks on the call. So I'll talk a little bit instead about the role they'll be playing on today's webinar. Leanne and Carrie are joining us as co-authors of the report to share their insights from the work that they've done and hopefully inspire all of us with some of those findings. Ross and Micah have had their hands right up to the sleeves as co-chairs of the Pan-Canadian Advisory Committee of this report, and we're helping to guide our conversation as well. And Christina is joining us, having had on-the-ground experience with taking this proactive approach to measuring and monitoring safety. And so we've got a great group of folks to participate in today's conversation. I invite you to join in this conversation as well at any point in the webinar. Feel free to add questions, comments into the chat, and we've got some time reserved at the end for that conversation. But without further ado, let's dive in. And he's in the center of this screen. He's on the image right now. Ross, turning it over to you.
So thanks so much, Jennifer, and welcome to everybody to this webinar today. My role here is to introduce the framework and talk a little about the things that we've been learning about trying to integrate the views and experiences of patients and care partners into this exciting new framework for the measurement and monitoring of safety. So let's start by thinking about this framework. And we need to recognize that over the last 20 years, there's been a lot of work thinking about the measuring and monitoring framework, or thinking about patient safety more generally. But we've also discovered that it's tough work. It's hard to make patients safer. And so this new framework gives us a broader range of approaches and issues to deal with moving forward. Next slide, please. I'll say a little bit about the background to this framework. A decade ago, a team in England led by Charles Vincent was asked by the Health Foundation to review existing patient safety measures. And they came back with a report that reviewed best practices in measuring and monitoring safety, not only in healthcare, but in other industries as well. And this report had a big influence on the work and thinking in patient safety. It was tested initially in England and Scotland, and then we brought it to Canada about 4 years ago and launched two collaborative learning demonstration projects to enable teams in Canada from coast to coast to coast to really take this framework and understand the ways in which it can be adapted to the Canadian environment moving forward. So let's think a little bit about what's in this new framework. The next slide outlines the 5 dimensions to this framework, and it starts with past harm, because we've learned a lot about the lessons that can be derived from past harm. And that's an important part of this framework as well, but it's insufficient to create safety. And I think the big insight in this new framework is that we need to have a broader set of lenses in order to understand how to create more effective patient safety. And the results of the work in the demonstration project and this approach has shown that we can create a more active engagement of staff who identify safety challenges and create a more effective culture that supports safer care. So each one of these elements in the new framework is really important. I said patient safety, which is the first element, remains important. We can learn from past experiences about when care has not been safe to derive new approaches, new ideas to improving the safety of care. But we need to do more than that. We need to, first of all, focus on reliability, whether or not the staff in a daily work have the information, the resources, the medications, and the helping hands to enable them to provide care. If they don't have that, without reliability, staff must improvise to provide care, often at the risk of endangering the safety of patients. The next element in this new framework is sensitivity to operations. And by sensitivity to operations, we mean, are staff alert to the care needs and the safety risks of their patients? Are they communicating effectively? Are they actively working with their colleagues to deliver safe care? So sensitivity to operations requires staff to be aware if care is safe for their patients on an ongoing basis. And if it's not, how do we create greater safety? The fourth element of this, anticipation preparedness, moves that sense of, is care safe today, into the question of, will care be safe in the future, in the next shift, tomorrow for patients? And this is important because we know patients can deteriorate quickly. So we need to be aware of which patients are vulnerable and what we need to do if those patients deteriorate moving forward. And the last element of this framework is integration and learning, taking the preparation and the learning from each one of these dimensions and bringing it together as a team, as a unit, to understand how to create safety at the front line and throughout the organization to enable us to be aware and to be prepared to provide safety moving forward. So together, these 5 elements provide the capabilities of staff to shift solely from focusing on preventing harm based on past experience to creating and enabling safety. And the next slide really shows what this evolution looks like. This movement from a lot of important resources that are available to prevent harm, our understanding of past harm, the lessons we derive from that, and the assurance and capabilities that we're developing in our organizations, to moving towards an environment where we create safety, where everybody has a role moving forward, and we're able to, as a team, be proactive and curious and inquiring about creating an environment that really enables safer care. So I want to then just talk a little bit about what we've learned from these 2 collaboratives moving forward. The next slide really outlines some of the key points of that learning. So a lot of this was around helping these teams to interpret this framework and make it real and useful in their own environments. So 19 teams from across Canada used this framework, and these teams came from a variety of different clinical environments, institutional environments, community-based care, and so forth, so that we could see the robustness of this framework in dealing with the safety issues moving forward. And frankly, a number of teams identified the challenges in taking this complex but really powerful framework and putting it into practice. And overall, they said it was effective, it was enabling, it allowed them to have a broader view and a broader role in terms of creating safety. So these teams reported a shift in how they viewed safety and felt enabled in order to make the safety role realistic and empowering moving forward. The other issue on this was the issue about engaging patients and care partners, the sometimes invisible but really critical role that they can play in enabling safety. And in the next slide, we really see this sort of identification of the ways in which patient partners can be part of this and the ways in which their role has not always been fully actualized moving forward. So we need to understand that patients are essential, but not always well used in terms of developing the knowledge and the tools that we need to prevent patient care. And in the busy work that clinicians are doing in daily work across the country, they often don't have the time and sometimes don't have the experience in talking to patients about how we can make care safer for them moving forward. So we need to think about the ways in which we can understand the roles and views of patients and care partners and integrate that with the safety work going on in this new framework to make a difference moving forward. So I'm going to turn it over now to Leanne and Carrie, who are going to talk about the work that we've done and the research, the result of this research, and the ways in which we can bring the views of patients and care partners to bear in this exciting new framework to create better care, safer care for people across the country. Over to you.
Great. Thanks, Ross, and Healthcare Excellence Canada for the opportunity to share our insights that builds on insights that we gained from the demonstration projects as well. And welcome and thank you, bonjour and merci, for joining us this afternoon, this morning, whatever time you're joining in at. The next question, please. So our overall guiding question, next slide, was really trying to get a sense, as Ross had mentioned, on how safe is care from the perspective of patients, families, care partners, and care providers. So before I go into sharing the key insights and findings, we want to provide you with an overview of this question. And as Ross had mentioned, we knew from previous research, from the demonstration projects and other work that both Carrie, myself, and others have been involved in, that how safety is experienced and what matters to patients and care partners can often differ from what we as healthcare professionals and leaders think safety to be, and felt that it was extremely important to get insight into this area. Next slide, please. And so we had a multi-pronged approach to develop, as I mentioned, the core themes and categories, but we also developed actionable strategies, which we'll share with you in more detail. And there were sort of three core components that we brought together to actually end up where we're at, where you'll we'll see in the report in a bit more detail, where we did an extensive literature review on qualitative, because we were very interested on how people are experiencing and feeling about safety. We also did primary data collections with interviews, and you'll see some demographics from that in the next slide, as well as these world cafes that Carrie will talk a bit more around, all to bring together to the final report that we're sharing some key insights to with you, with Micah, after we sort of go over our approach. So our next slide, please. So the interviews, as you can see too, we actually conducted a series of healthcare provider interviews along with 15 care partner and 4 focus groups that totaled 13 patients and care partners. Before the actual semi-structured interview began, Anne and Virginia, who I think are both on our call, actually oriented the patients and care partners to the monitoring, measuring safety framework that Ross had also oriented to the group, if you haven't seen it before. So they were socialized to this framework, and then a series of questions were asked. We both did inductive and deductive, but we'll be sharing with you more of the deductive findings that are mapped out to the actual framework that Ross had mentioned as well. Next slide, please. As you can see, we actually did have some diversity across Canada in terms of drawing from Ontario, Alberta, British Columbia, and Saskatchewan. However, our patients were mainly comprised of females, middle-aged, and highly educated. There were some differences related to levels of education and economic status as well. We did try to efforts to reach out through our advisory committee that Micah and Ross had co-chaired to actually get more diverse populations to represent the diversity of Canada, but obviously not as much as we were hoping for, and just want to flag that because we are interested in future inquiry related to this area and would be interested in talking either here or offline on how we might be able best to do that. And then the next slide, please. And this actually, that's a little bit out. The next slide. Next slide. These are
this is, I think I'll pick up here, Leanne. Thank you.
Yeah.
And, you know, as Leanne mentioned, we conducted a lot of interviews. We did a lot of focus groups, and we learned a lot about how people, so patients, family members, care partners, experience safety in the healthcare system. And in those interviews, they talk about what works well, what doesn't work well. And we got a sense from these interviews and focus groups, started to get a sense of how maybe we need to move forward to create safer care experiences. But what we did after the interviews is we pulled people together in what we call a World Cafe. So we had healthcare system leaders, we had caregiver partners, patients, members of our advisory committee come together to learn about what we found, which Michael will talk about in the upcoming slides, but also come together and start to make sense of what we found so we can turn them into actionable strategies. Because what happens a lot in research is we spend a lot of time collecting data, but we don't always spend a lot of time thinking about how do we action the things that we found? How do we actually start to think about what safety strategies for the future could look like that are driven by the priorities and preferences of patients, families, and care providers. So the World Cafe allowed us to do some small group learning, some co-design with Dr. Julia Moore and her team that did a really effective job. And then Virginia Flintoft and Anne McLaurin, I want to credit them because they really helped us link the findings to the framework, to the measurement and monitoring of safety framework. So they really helped us make sense of the data in relation to that. And so we were able to show those connections in the report that's been published, that's on the Healthcare Excellence Canada website, to show what those different elements of the framework look like. So what do they mean? But what do they mean in the context of what patients and families want from the healthcare system? So it pulls those pieces together pretty effectively. And I credit the team for helping us make sense of all of that. But that's sort of the process of how we compiled and made sense of the data and linked it to the framework. And now I'm going to hand it over to Micah to talk more specifically around what we actually found and how it does link up to the measurement and monitoring of safety framework. So over to you, Micah.
Thank you, Carrie and Leanne. Let me first say what a privilege and joy it's been to have been involved as a patient partner with the research project and a remarkable team. I also want to acknowledge the other two patient partners who served on the research advisory committee and the patients, care partners, and providers who contributed and participated in various ways. I will provide in the next few minutes a brief reiteration of each dimension of the measurement and monitoring of safety framework. And I will share a patient's story to illustrate each dimension from the patient or care partner perspective. As you've already heard from Leanne, there are differences in how healthcare providers and patients perceive safety. As you listen to the brief accounts of patients and care partners that follow, I ask you to think about the safety dimension of the framework through their voices. Sometimes the dimension is very apparent, sometimes not. Our hope is that through the sharing of the research findings, healthcare providers will come to better understand and appreciate patient perspectives and their contributions to safety. Next slide, please. What did patients and care partners tell us about safety? Among what they told us in our study was, I did not feel safe there because I did not feel heard. I did not feel safe to express my emotions. Safety needs to be based on facts and feelings. Next slide, please. First, let's look at how we address harm. The focus most often is whether care has been safe in the past, the rear view mirror approach. Next slide. Widening our view of harm. More recently, we have widened our view of harm, largely because of what patients and care partners have shared. Beyond physical harm, they cite, for example, psychological harm, harm from overtreatment, or delayed or inadequate diagnosis. Next slide, please. What did patients and care partners tell us about harm? We heard from a woman whose husband went to hospital twice with uncharacteristic chest pressure and pain. And I quote, "Both times his cardiac issue went undiagnosed. In response to his expressions of concern and pressing for answers, he was repeatedly told, 'It is not your heart. Your EKG is fine. It's painful heartburn.' He felt judged and ashamed for being there, thinking others needed the care more. This affected his seeking help a third time. This experience was dehumanizing for him and for me as his wife. We just kept getting, 'You're fine, you're just anxious.' That makes patients hesitant to speak out again. 3 days after his last hospital, my husband died of a heart attack during our family vacation." Next quote. The next slide, sorry. Reliability, as you see here on the slide, is another dimension of safety from the measurement and monitoring of safety framework that asks if our processes and clinical systems are reliable, assessing whether a task, a process, or an intervention will be done as specified. Patients and their care partners have a perspective on what reliability means to them. Next slide. One of the people we interviewed was the mother of a young adult son with complex, recurrent, and serious health issues. She told us, "I emphasized to the care team how calming it is for Ben to hear music. And I asked them to please hum or sing when entering the room or during an unpleasant procedure, as it would help him be comfortable." They put it up on the whiteboard as a note. The staff actually sang through every procedure, and each time they gave him a needle in his tummy, and the whole team sang when they took out the ventilator tube. They did it because I, his mother, told them this therapeutic intervention mattered to Ben. If they hadn't done it, it would have been almost harmful. The fact that they consistently did this intervention was so positive for Ben and for me. A comment on this account: the relevance of this account to reliability may not be seen the same way from a clinician's perspective. For many patients, feeling psychologically safe and or personally secure are important, and having staff consistently perform interventions to support psychological safety is key. Staff looked at clinical processes, etc., as relevant to reliability. For the patient's mother in this story, the function and positive impact of having staff singing as a calming measure reliably enabled psychologically and potentially also physical safety for her son. This particular example also speaks to the next dimension, sensitivity to operations. Next slide. This dimension in the framework, sensitivity to operation, speaks to whether care is safe today, in the moment. This requires listening, seeing, perceiving, and acting on information gathered. Next slide. What did patients and care partners tell us about sensitivity to operations? From a patient's from a patient's daughter, we heard this, and I quote, "The powerlessness of staff really struck me, and that they felt they had so little authority. They did not want to cross somebody else's decision, even though there was mom's life and safety at risk. One licensed practical nurse slipped me a little piece of paper with mom's electrolytes and vitals for the day on it. She said, I don't know if I should do this, worried about crossing the line. Despite the way they operated on this unit, not patient and safety first, this licensed practical nurse found a way to listen and respond to my concerns and fears. The next slide. The dimension of anticipation and preparedness asks whether care will be safe in the future and focuses on possible sources of future harm and how to become more resilient to them. Don't wait for things to go wrong before trying to improve safety. By the way, in this photo, Wayne Gretzky is evidently not best prepared. The image of him with a helmet that we could have used had him wearing the LA Kings jersey. As you can see, Canadian pride won out. Next slide. What did patients and care partners tell us about anticipation and preparedness? One patient who experienced harm told us the following, and I quote, "I probably still would approach healthcare with that same level of trust that I had before, but now I don't. I bring not cynicism exactly, but a critical eye. I look at the environment and I gain a sense of the provider for their comfort and ease, their communication, their stress. I pick up cues from the very start. I've done my homework and I'm prepared to have conversations at that level. I want to know how willing they are to share knowledge with me and delve deeper." Next slide. Integration and learning. This dimension has us asking the question whether we are improving and learning. After all, a learning system is a safer system. Next slide. What did patients and care partners tell us with respect to integration and learning? The mother of a young child with a complex health history told us, "I created what I call an emergency room one-pager, which has all the pertinent basic information like his date of birth, his health card, along with the description of what my son is usually like: happy, content, energetic, and what his capabilities are. I did this after his first big seizure because how he presented then was so different from his normal self, based on which we convinced the doctors to look further. It taught me to give emergency doctors some really good basic information quickly in a matter-of-fact way. This objective piece of paper says, this is who this person is, what they're like, this is their normal baseline. It has been helpful in frequent emergency room visits and much appreciated by doctors. You really cannot make assumptions about a patient based on their presentation in the moment." A comment about this account: the mother updates this one pager and keeps it current. She uses it as a tool to create safety for herself and her son. As a living document, it comprises the integration and learning gleaned from her son's health history and care. This concludes my part. Over to you, Christina Denisic.
Good morning or good afternoon, everybody, and just want to acknowledge that I'm here in Saskatchewan on Treaty 4 land. Thank you so much for this opportunity. Maybe I can get the next slide. Thank you. So I wanted to share with you, we in Saskatchewan were one of the privileged that were able to be in the second cohort for the measurement and monitoring safety framework projects. And we brought on a patient family partner. And this actually is Al, and Al was the husband of our family partner in our project. And I just want to share with you for Adele told us, and this continues to remain a vision of safety, in that prior to this, Al is a resident in a long-term care home in Yorkton. And prior to that, Safety for our providers and our care team looked like a prescription for antipsychotic medications. It looked like a physical restraint in the bed. It looked like working through their schedule, not Al's. And how Adele described it, she knew that that wasn't safety for her. And she advocated a lot. And this picture is Al in no restraints, off the antipsychotics. And when she walked in the room that morning, he was sitting up on his own free will, making his own decisions to do so. And that was safe care in her mind and Al's mind as well. So I guess for us, I mean, we heard earlier that, you know, safety isn't always about the absence of harm. It is about the presence of safety, and it looks different for many others. And I think what we had to learn is that, you know, engaging with residents, I'll say residents because it's long-term care, or patients and family members, really, we heard earlier that care providers often find it difficult to talk to our patients or our family. But I would challenge that what we also have difficulty with is listening. And we have difficulty listening to really hear, to understand, and to also have a commitment to take action. And so I think for someone who has been in the health system for a very long time and has always, we've tried to find a way to reduce harm. But I would suggest that, did we have a mindset that was to reduce harm, or did we have a mindset to have a presence of safety? And really, this whole framework changes your mindset. I would also suggest to you as a leader, it's hard. We have a mindset, changing a mindset is very difficult. It's exhausting work. It takes tenacity. It takes perseverance. And I think that what the measurement and monitoring safety framework offers is, I'll go so far as to say, I think it's more than a secret ingredient. It may in fact be the secret sauce. And in fact, it might be the secret bullet or the magic bullet in us trying to get to a system that is safe all the time, every time, and meets the expectations of what those that we serve want, and those that are our family members. I would also just offer some advice in terms of what we also found in the project with our family partner is, I would say that don't confine your representative or your partner, and don't predetermine their role. Really give them freedom and give them your trust. Make sure that they are really an equal partner in everything and at the table. And I would say, listen, and really listen. And as I said, be prepared to jump in with trust, because I can tell you that in our project, what we thought was perhaps our pathway, our patient rep really, or our family member really did change our view. And because of that, we really did see some huge benefits. So again, Al will always be a representation of what safe care is from the eyes of our resident and from the family's perspective. So thank you for this, and I will turn it back over to Jennifer.
Thanks so much, Christina. And thanks to all of our fantastic panelists for sharing both the findings in the report and then bringing to life the possibilities coming forward. And I'd invite all of our panel to come back on screen so that we can continue this conversation. And as they do, invite anyone to add comments or questions into the chat so that we can have a dynamic conversation together in this virtual way. And to start that off, excellent, everybody's back. To start that off, I'll start with a dialogue that has been happening in the chat, and really appreciate appreciate, Esha, the feedback and the comments that you've included in terms of the importance of equity and equity as foundational to safety. And Ross, I know you started a response in the chat. I'm wondering if you wanted to elaborate on that now that we've got the opportunity.
Yeah, no, I think we recognize that equity is a critical element in quality and safety. And I thank you to Esha for really bringing that issue to bear. It's something that is not always evident to people in the clinical environments, but it is very critical that we understand who it is that is in front of us as a patient, a client, or resident, and how we need to communicate in order to be effective, and how we need to listen in order to be effective as clinicians or managers or care partners in this environment. So I think this is a real interesting issue and something that we need to explore more to really understand how we now frame this issue in the context of this new broader approach to safety. And so it's a very valuable piece to bring forward.
Thanks so much. Go ahead, Leanne.
Yeah, so perhaps I can build on this as well too, and that's why we sort of, in the work that Carrie and I led with others, we also became cognizant when we started to look at the demographics that we had were from our participants, and sort of realized, and sort of halfway through we sort of realized, obviously how important looking at equity and the differences in cultures and racial aspects as well in this work, and safety, meaning different things likely. And in hindsight, obviously the conversation around 4 years ago when we started to undertake this work would have been beneficial to engage people from different perspectives right from the get-go, because I think what we found too is even the way we had constructed our interview guide wasn't necessarily culturally sensitive to other folks. And so that was why I sort of put forward, and as we talked about this too a couple of days ago when we were preparing for this too, that we also know that future research needs to address this in ways that are meaningful and have engagement right from the initial sort of conceptualization of the research design and studies to really help get at that sort of nuances of each of the cultures where there's some nexus points, but we also acknowledge that there's people experience healthcare and safety very differently. And that needs to be part of our sort of dialogue moving forward that will help guide obviously in new interventions and new ways of viewing safety beyond the absence of harm.
Thanks, Leanne. Just checking. This is my moment to try and see if I can understand people's body language on Zoom to see if anyone else immediately wants to jump in. Carrie, it looks like you unmuted. Go ahead.
Yeah, thank you. Thank you for that, Leanne. And I'll just add to that, in learning how the framework could be activated, a lot of it is contingent on creating spaces for people to feel safe to speak up. And as we know, people that have experienced decades of discrimination and injustice, that's an extra layer of complexity. So how do we consider that in creating those enabling spaces to speak up in consideration of past harm, psychological harm over many years? So it's a really important question. It's one that requires really deep attention and thought, and very much from the get-go of the formation of the research question and the design of the study as well. So I'm really glad that that was brought up, and I think it's critically important that we shine a light there and co-design the research before we actually do the work to understand how we can make care safe for everyone.
Thanks, Carrie. And maybe this is a good moment to mention that this was one of the things that sparked some work that's going on now in terms of looking at updating the definition of patient safety in a way that will draw from a whole range of perspectives across the country. And if that's something that interests you, I encourage you to, we've got updates on that coming out in the newsletter in terms of opportunities to contribute and to look at that definition as it evolves. So encourage folks to do that. And I note in the chat, for instance, thanks Susan for emphasizing that stigma is also an important dimension for us to think about in this context as well. So I wonder, I'll move us to another question that Julie posed in the chat in terms of, could we expand this type of analysis to all 6 dimensions of quality, or do you feel we should specifically call out patient safety? And I'm wondering, Leanne and Carrie, given your roles in the report and that you presented the methodology piece, if you'd like to start on that, and then I'll invite others to come in as well.
So I'm happy to start and then obviously have that built on. But, it's been a conversation I'm thinking with Ross for, a decade, maybe 2 decades, in terms of, where do you place safety, quality? Safety is a dimension of quality. And I think where the work with the framework, as well as the qualitative inquiry that we undertook, with some of the framing of the measuring and monitoring framework in the background, was really to expand safety broader than the absence of harm. And as you saw that when both Ross presented and then Micah also then sort of expanded on the way in which we oriented people to a broader definition in a way from the get-go to sort of talk about, so as Carrie mentioned, psychological safety, dehumanization. It's basically how you feel, how we make you feel when we're providing care to you is about safety, but that's also around quality. And so I think for me, it's hard to distinguish and nuance out quality and safety because they're so intertwined in my own view. But that's sort of where my perspective is, looking at more of an integrated way of safety, then also is really looking at a more integrated way of quality of care as well. And quality as an outcome as well. It's around the experience and how we are making people feel, as well as how we're impacting their clinical outcomes and their experiences.
Thanks, Leanne. And I note some other folks in the chat chiming in on that front. Carrie, did you want to jump in?
Yeah, and just adding and building on what Micah and Ross had said, as well as Leanne, is thinking about, whether we think about the definitions of the framework or different dimensions of safety. If we think about the context of a learning health system, where we're constantly, looking at what information are we collecting, where's the information coming from, do we have this space to really, really intentionally make sense of what we're finding, and then using that to improve care, and knowing that we're never going to be done. We're just going to be on that cycle of making sense of information, improving care. And so you can see there all the dimensions coming together: adapting, learning, quality, safety, person-centeredness. And so all those pieces start to coalesce if we just really be reflective in our practices, which is easier said than done. I'm not a clinician, so I don't, I can't speak to what it's like to be on the front lines and how hard it is to find that time to reflect. I think just really honoring what our patients and families and community have to say about their care and working with them to try to move the dial a bit. I think in activating that, we are hitting on all those dimensions of safety, no matter how we choose to define it.
Thanks, Carrie. And Christina, I see you've unmuted, so I'm assuming that that's a signal to turn to you. I'm wondering if you can also maybe consider weaving in the next question, which is around, it's hard to change mindsets. How do we do that?
Well, great segue. And in fact, that actually was something that I was hoping to comment on. And it came back to maybe a few comments ago in the chat about, how we need action and how can we do it. One of the things that we saw in our, I'm going to call it a project, but we quickly learned it wasn't a project. It really was about thinking very, very differently. And when we took it to the floor with our providers, part of the wake up was understanding the different types of harm and coming to the realization. I mean, most care providers, we're very proud of no physical harm, but and could identify some psychological harm. But having said that, when they started to look at the other types of harm and starting to understand those perspectives, I would say that's when we actually started to see, I'll call it the mindset change. The conversations started to get way more robust. We started, care providers would say, we have a very noisy unit today. I think we might have, that might impact, Mr. So-and-so, or different things like that, or, light impacts so-and-so. I think, we've got a very bright day today. Maybe we should draw those blinds on the east side for the morning sun. So it was just those things. But again, understanding that harm was way larger than just what I would call traditional physical harm. And as again, a bit of psychological harm. So I just wanted to draw, a parallel to that. That's what actually was kind of a tipping point for us as we moved forward, was that.
That's great. Thanks, Christina. And I'm wondering, maybe this is a segue to Micah, and then I see Ross, you've unmuted, so I'll come to you next. But Donna's commented on the chat about one of the ways, and I think you've just done that really effectively, Christina, of looking at changing mindsets, maybe through real life examples, real world examples. And you shared so many precious examples as you shared the results from this. So I wonder if you just want to talk a little bit about that.
Thank you, Jennifer. Yes, I noted Donna's comment, and I agree with it. I think that perhaps this study and our evolving understanding about the important roles that patients play and how essential it is to engage them in discussions and experience of care, especially when, as there is now, so much pressure on the system and on healthcare providers, which, and this is a very personal viewpoint, makes the healthcare less safe than it's been before. I'm sad to say that, but that's my sense of it. So we are essential, we patients, to making a change in that. And I hope this study contributes, as the other work of organizations like Patients for Patient Safety Canada, to keep bringing forward that notion, that message, because enlisting patients is integral to shifting mindset.
Thank you so much, Micah. Couldn't agree with you more. And Ross, you look poised to jump in, so over to you.
Thanks, Jennifer. I think this is a great conversation because it really reminds us that safety isn't just that no bad things happen. Safety is about creating an environment where people feel respected, they feel that they have a part to play, they feel they can rely upon their colleagues, they feel their staff members, their managers are all working together to create this learning environment, as Carrie says, this opportunity to really recognize that you can rely upon others when you need them. And too often now in our environments, I think we aren't paying enough attention to this sort of sense of common need, common collective, common focus on ensuring that patients, clients, care partners, others are really looked after on an ongoing basis. And you could sense this, I'm not a clinician either, but when you walk into a unit that is really well run, there's a different feel to it. There's a different sense to it. And I think that's what we need to look at. So we often define safety as the absence of things, but really there are some elements of safety that enable that to be the case, right? So we need to focus more about the issues of teamwork, communication, confidence, support that are the critical elements that help to bring out this kind of environment for staff and for patients.
Thanks so much, Ross. And perhaps that and Micah's comments feed into the next question that came up in the chat, which is, the pandemic has changed so many things in the healthcare context. Changed the ways, in some cases, we provide care, changes the way we seek care. How do you think that the pandemic and the changes, the ripples of changes that have resulted, will affect this work to create safety? And I wonder, Christina, you're there right now. I wonder if you wanted to start us off on that front.
Sure. I hope what the pandemic did was, I can talk, of course, from a long-term care perspective with the things that we did. Our perception of safety was, for lack of a better phrase, I'm going to say locking down our long-term care homes, making sure we didn't have COVID come into our building, and various aspects of that. I think what I hope the pandemic did was teach us that perhaps our view of how we maintain safety for residents wasn't their view. And the same with families, and that we learn from those. And it highlighted for us, again, listening to those residents, listening to families, and the need to have families close, and the need to have families in partnership for the safest care possible. So I'm hoping that it was opportunity to learn, and that we take that lesson and carry it forward, and don't relive that. So that would be my perspective on that.
Thanks so much, Christina. Leanne, looks like you're ready to jump in.
Yes, just to build on that, Christina, what you shared as well too, and I know Carrie and I have been involved over several years in some work on an international learning collaborative on fundamentals of care. And so what it reminded me of was our need to really reacquaint ourselves with person and family-centered care, to your point, Christina, around how we really need to authentically engage the people we're providing care to around their care. It's listening to patients and care partners around what matters to you, what your life was like before. And I think there was a comment earlier around, what does a normal day look to you? It's really fundamental questions, not basic care, but fundamental questions related to what matters to the people we're providing care to. And then from a community perspective, population health, that as an aggregate, but really it's reacquainting ourselves with person and family-centered care and professional practice in order, and creating conditions to recover from I would say some dramatic effects that we had to do in terms of provisions of care and shifting within our hospitals and other healthcare sectors to look at how we sort of learn from, some of the innovations, and it's around patient preferences and care partner preference too, because some people would prefer, and I did some work early days around technology, around people preferred to actually have virtual care because it meant that they didn't have to travel 2 hours and they could dial in and felt connected through technology and iPads for chronic kidney disease. And so it's really thinking through a redesigning, co-designing, as Carrie mentioned, healthcare systems that transform ways in which we are reacquainted with people that we're providing care to.
Thanks so much, Leanne. And some great examples coming in the chat in terms of how practically that can happen, and ways that can happen. And maybe that leads me to circle back to a conversation very early in this webinar, where I think, Ross, you actually started this conversation, but several of you commented on it, that the challenge is, how do we make it safer to talk about safety for care providers and patients? How do we open up some of those conversations? And Leanne, I'm not sure if you're still unmuted from last time or if you're just unmuted, but I wonder if you want to start us off, since you are.
You know what, actually, I was following the comments as well too, so I'll reserve my comments and sort of pass the baton. I forgot to.
Fair enough. Carrie, were you Yep, go ahead.
Yeah, no, I think that's such a great question. And, in looking at our interview data and just some of the experiences I've had in talking to patients and families, a key trigger to opening up that space is articulating how we value that other person, whether it's a patient to a provider to a patient, a leader to a provider, whatever direction you want to go in. Sometimes we think about it, but we don't say it. So one example of an interview excerpt that really stands out for me is a caregiver was talking about how she felt really comfortable talking to her specialist, and that he really, she felt like she could open up and that she trusted him. And we were wondering, well, how do you build that trust? And she said, well, he said to the caregiver, so he said to her, "You are the leading expert in your son. You are the expert. Let's work together to figure out how to move forward." So by her feeling valued openly by her specialist, opened up that space, took down that fear, that wall, to have an authentic relationship and conversation. So again, the key point being, do we openly value each other and express that? And it's amazing, that point of connection that you make, which then is the enabler to build trust. So there's something about that as a trigger point. And I think we often think it, but we don't articulate it. And I think we could do this in our everyday life in terms of building our relationships with anyone, is telling them why we value them. It's pretty powerful.
Mm-hmm. Ross, I see you've unmuted. Did you want to jump in?
Yeah, just make an additional point, because I think Carrie's really talked about this in a very articulate fashion, and the importance of the relationship between providers and between patients and care partners. But it also has to do with the broader roles in the system. And one of the teams that participated in the first collaborative had a very interesting experience where the staff discovered that housekeepers had an unappreciated, unacknowledged view about the patient, and they often spent more time in the patient than many of the providers. And so their insights were very valuable as the staff started to think about how do we create an environment that's going to ensure safety for our patients. And so it's around, again, this idea about really focusing on the whole and not focusing on individual parts or roles or specific issues. And too much of safety has really been about mechanistic approaches to safety instead of having this more organic, encompassing view about creating an environment where everybody's respected and seen as a participant in creating safety for patients, clients, and care partners. So.
Thanks for that, Ross. And I certainly remember an example from a few years ago, not part of the collaborative, in a community setting where we had similar conversations with the receptionists in a clinic who were trusted and respected members of the team, but maybe unrealized the role that they could play. So there's so many others who have that potential. And Micah, looks like you're ready to jump in. Over to you.
Thank you. Just picking up on some of the threads, I think what attracted me as a patient to the measurement and monitoring of safety work and its application in Canada is that it's not about layering on, because clearly we've heard that people have their hands full in the system. It's burdened. And so if we think about creating safety as another layering on, I think it's beginning to look very discouraging. I think actually the words are in the chat, enabling, and I think Joanna put those words there. Enabling is an important concept. Safety is already present. How can we unlock, elevate, and help it flourish in people and systems? That's Joanna's quote. And yes, and making room for engagement within that.
That seems like a perfect wrap actually on our conversation. And I will point out, Liliana has just added in the chat that there was different perspectives, different approaches that were taken to the pandemic, and the opportunity to learn from those who were maybe outliers, who took different approaches, who took courageous leadership, whether in that context or in others. And certainly invite those, if you're interested in that particular environment. There's some great opportunities. Carrie, I see your note in the chat as well. You'll also find some great case studies through webinars that were provided as part of Essential Together. So if you're interested in walking a mile in the shoes of those who took an approach that would allow us a different path, and then inspired many others to follow their examples, there's some opportunities there as well. And so with that, recognizing, having a look at the time, I could continue this conversation probably all week, actually. But I recognize that we are close to the top of the hour, or the half hour if you're joining us from Newfoundland and Labrador. And so I invite you to, as the slide suggests, download the report. There's tons of great information in there. And lots more to continue this conversation with. There's a short poll up on the screen as well to help us be part of a learning system and continue to improve these kinds of opportunities with and for you. So I invite you to do that. And then absolutely, most importantly, invite you to send a huge thank you along with me to all of our panelists today. This was a fantastic conversation, and a conversation that I know for me has inspired lots of thoughts about what we might do and how we might continue to strive towards excellence in care, building on the work that's been done, the insights that have been shared today. And so huge thank you to all of you, as well as to everyone who took part in the study that made today's webinar possible as well. So thanks so much, everyone, and hope to see you again soon. Have a great day.